There are Medicaid programs that help people get care and support at home instead of being forced into a facility or being left unable to complete needed activities of daily living. These programs are called HCBS, or Home and Community-Based Services, and many people have never heard of them. In this episode, we're breaking down HCBS so you know who may qualify, how the system works, what services are offered, and the current state of play from a policy standpoint. Okay, so let's take one of the most confusing parts of the healthcare system and break it down, because I know Medicaid HCBS are game-changing programs for patients and families and those who just need additional support in the community. But they can be really confusing and not a lot of people understand them. So let's start high-level overview. What is a Medicaid HCBS program? What does HCBS even stand for?
Elyssa, I think you got to step back a little bit and just let's remind ourselves what the Medicaid program is.
Even better.
Okay, Medicaid, it's the largest health insurance program in our country. About 80 million people receive their health insurance through Medicaid. It is implemented in a partnership between the federal and state government. So there's federal funding, which is almost 70% of the funding, and then there's state funding. And every state is implementing this program a bit differently. And it's targeting vulnerable populations, right? Whereas we think about Medicare as health insurance for all people over 65 and people, workers who are disabled. Medicaid is for children living below the federal poverty levels, pregnant women, people that have aged into poverty, and people with developmental disorders or intellectual disabilities are part of the population covered by Medicaid. So Medicaid is essentially our healthcare safety net insurer for people that are in these categories. And within this within this program, we have this topic of HCBS, Home and Community-Based Services. As everybody knows, we talk a lot about home-based care. This is what we're passionate about, and this is our topic. And Medicaid Home and Community-Based Services is one of the most important areas of care at home. It is the way that people can age in place. It's a way that people can, if you have developmental issues or children with complex healthcare needs, get care at home rather than in the institution. Medicaid was launched around the same time as Medicare, right? The same law, say 1965. We get a Medicaid program. It wasn't until later that home and community-based services really became a robust part of the system. In the 1980s, there was growth. And I think the thing that everybody should be aware of, just because of the historical implications, just one of a more interesting and important historical points that we should sort of pay homage to, quite frankly, is Lois Curtis, Elaine Wilson. These were two people living in Georgia who had some mental illness. They had some intellectual issues, but they wanted to live in the community and not in an institution. They were actually forced to if they were going to get the care they needed, to get it inside of an institution. And this was around the time after the Americans with Disabilities Act had been passed. And they actually, Curtis, Wilson, they challenged the idea that the only way they could get help was in an institution. They wanted help at home. And they felt that the Americans with Disabilities Act required that they get their public support in the least restrictive setting, okay? And so actually they, with the help, I think, of the Atlanta Legal Aid Society, they challenged then Georgia Human Resources Commissioner Tommy Olmstead in their policies, and ultimately won in the Supreme Court. And so this Olmstead, it's known, as the Olmstead decision. This Olmstead decision in the late 90s, I think 1999, was a critical landmark decision in federal policymaking, which said that, people, when implementing a federal program like Medicaid, people are obligated or have the right to get care in the least restrictive setting. And so that really propelled even more of a focus on home and community-based services. Now, I say all this, I'm trying my best not to allow you to talk at all. I'm just going to just keep talking. It's the other thing we haven't talked about is like, what are these services? Like, what are we actually talking about people getting? Okay. Think about things like home health aid, personal care services, homemaker services, transportation. It's a community service. If you need special transportation, Meals on Wheels would be considered a Medicaid home and community-based service. Another area program we really should spend some time talking about in more detail at some point would be adult day programming. So day programs are a type of community-based service that are really important. Then there's actually a special area that sometimes uses day programming called PACE, or Program of All-Inclusive Care for Elders, which is a type of home and community-based care. Other things actually that are not as common but actually do occur within home and community-based services, medical alert things like fall alert systems in homes, home modifications, and other monitoring services. So it's a broad category. The whole idea is really what can be brought to people that would otherwise need to be in a facility. What can be done to support them in a less restrictive, often lower cost setting, being their home or community setting. And there's a lot more to this that I'm sure we'll get into.
Yeah, Dr. Landers with the encyclopedic knowledge. I mean, I learned a lot in that origin story that I didn't even know before. So that's incredibly fascinating. And so we know Medicaid is huge, like about 1 in 4 Americans receiving Medicaid support in some way over the course of their life. And home and community-based services, there are a wide range of services, some medical, some non-medical. Let's go to the state-by-state view. I think the last that I understand, every state participates in some way in Medicaid, but all of these things are different from state to state. So does every state have Medicaid HCBS? How do you go about figuring out what's available? How do the states figure out what they're going to make available?
Yeah, the Medicaid. So, we talked about this already. I'm kind of a health policy nerd. This is stuff that I enjoy and the detail of it. But I've got to admit that Medicaid is daunting, even for someone that spends a lot of time reading about and thinking about health policy. Medicaid is daunting because we essentially have 50 different Medicaid programs, right? Every state is implementing Medicaid somewhat differently. There's some broad brushstroke things that we've already talked about that are kind of across the board, but there's variation. Now, the reasons that there's variation is that there's these mechanisms that the states can use to make decisions about how they organize their programs. So they have something called their state plan, and the state plan applies to everybody in Medicaid in the state. So if they include home and community-based services or certain services within that state plan, then they're part of the state plan. There have also been, over the course of time, Congress has provided opportunities for what are called waivers for the states to kind of be more creative with their Medicaid programming. So there are what are called 1115 waivers and 1915 waivers and sections of each of these that apply to different circumstances. And these allow things like the states to make decisions to have a managed care company manage some of their Medicaid programs. It allows them to have specialized programs targeted at specific populations for their Medicaid programs. So it's this state level individualization that can be really confusing. Also, the other thing that has been a bit of a moving target in terms of just understanding, getting your arms around it, is that the Affordable Care Act, or quote unquote Obamacare, had a massive Medicaid expansion opportunity, actually for in some cases younger able-bodied people that were at lower income. And so in different states opted into that expansion in certain ways. And now, just earlier this year, we've had Congress and the Trump administration passed the quote unquote One Big Beautiful Bill Act that had Medicaid changes within it, and some of those payment cuts and things that impact eligibility. And so Medicaid has been changing. It's been changing in different ways at the state level. It's changed at different ways at the federal level. So it's a lot to get your arms around. I was a little worried about us talking about this because it is such a complex topic that has different nuances. I think if we want to make it simple, like if we want to simplify it, there's a few lenses that we can simplify Medicaid and simplify HCBS through. So one simplification is that Medicaid is the medical safety net in the United States. Okay, Medicaid is the program. It's the largest health insurance program that ensures access to medical care and long-term care services and community services for people that are vulnerable because of various reasons: age, disability, poverty, youth, what have you. Another lens to look at Medicaid through is it's a massive public program, right? And I know that this was part of the conversation earlier this year. This is a program that's grown a lot. I think it's somewhere right around $800 billion a year in government funding for it, and it has a lot of implications on our overall budget and overall economic health.
Okay, so going back to how Medicaid's administered at the state level, my understanding is that some programs are mandatory versus optional. How does that work? Because I think Medicaid HCBS, if I'm not mistaken, is one of those optional programs, which is part of what makes understanding it at the state by state level so complex.
The core Medicaid program includes a pretty narrow home health provision. It actually includes extensive options for institutional care. Mm-hmm. So there's this institutional bias in the core Medicaid program. Okay. Maybe within that core program, somebody can get home health services, kind of like after a hospitalization, some of the circumstances we talked about when we talked about Medicare home health, some narrow situations. But when we talk about Medicaid home and community-based services, there's so much more broad and holistic, homemaker services, case management, housing related supports. So the issue, when we think about home and community-based services, not only are they different in different states, they're not all required, right? The core Medicaid law doesn't require that all of these are implemented in the same way, or that all of them are even implemented in every state. So the states have a lot of discretion. One of the reason this is not just sort of a footnote is that when we have Medicaid policy change, like the one that Congress has just recently passed, that puts pressure on state budgets. Let's say something called provider taxes are implicated, or other things that change the federal matching formulas for the states. Their budgets are going to be constrained, and they can't touch a mandatory program. You can't cut you can't cut back on something that's mandatory, but the optional programming could be at risk. And so, there's some fear in the home and community-based care world that some of the pressure that this new law will place on Medicaid will lead to some, cuts to the home and community-based services within Medicaid. We have to just stay vigilant, advocate, and, work with policymakers so that doesn't happen.
Yeah, absolutely. And I do want to talk more about the potential implications of H.R. 1 or the One Big Beautiful Bill Act, like you said, in a little bit. But I'm just going to go ahead and wager a guess that since everything else varies on a state-by-state level, the application or eligibility for Medicaid or HCBS at the state-by-state level also varies. Is that true? And would I just go to my state Medicaid agency in order to get started? Is there any sort of a standardized process?
Yeah, so you have to apply to Medicaid to get home and community-based services, and you have to meet the income and also the medical or functional criteria that are required. So it's actually usually called a nursing home level of care assessment. So home and community-based services are typically offered to people in the home and community that actually meet the criteria of being eligible for care in a nursing home. Okay, we're talking about a highly vulnerable, functionally limited, chronically ill population. This is not These are not services that are used, for convenience. These are things for people with serious issues. So they need to get an assessment. And that assessment is a bit different in different states. Who does the assessment? In some places, employees of the state government do the assessment. In other states, you have contracted firms that do it. Managed care plays a role in some states and how these are implemented. So a lot of variability, but you've got to apply to Medicaid. You've got to meet the core income and medical functional criteria to be eligible. And you also need to meet that nursing home level of care assessment in order to be eligible. And then in most states and managed care plans, if the state has a managed care plan running, there's an interdisciplinary team or I should say more of a case management model. When we think of something like PACE, there'll be an interdisciplinary team, but in home and community-based services, there'll be a case management model often, and that will make some determinations about who gets what, when, and why. And it's individualized. It's different in different states. It is hard to generalize.
Yeah, it sounds like it. I think I'm following so far, but let's go further into what that looks like for someone who's receiving those services. So you've painted the picture that the need is high. How does that help someone with their day-to-day life, their activities of daily living, their integration into the communities in which they're already living?
People want to get care in their home setting, right? The home is comfortable, it's familiar, it's more connected to family and community. And so home and community-based services within Medicaid are very much valued by families and by people, care recipients, because it helps them stay independent at home. And again, these are people that are eligible for care in a nursing home. So, and they want and need that a lot of care and a lot of help. And they're electing to get it, at home. Home health aides, personal care workers, aid and attendance services. These are I'd say the base layer, the foundational part of home and community-based services. This is, home health aides are the most, critical, people in care at home and long-term care at home. They do all the hard work, help with bathing and dressing and other hygiene issues, and maybe can help with feeding and other things that somebody, like you can imagine somebody with neurological disease or paralysis or developmental issues. They need a lot of help with the basics, home health aides, personal care. But again, somebody might need to get to their doctor's office or to get to a community center for socialization, so transportation. We talked about aids, transportation, which are all really important. None of them as important as eating. And so nutrition also a big deal. Meals on Wheels, access to meals, and sometimes homemaker services that help with meal preparation. So nutrition is a big part of home and community-based services. Again, we're talking about the basics of life here for people that otherwise would have their needs unmet or would need to be in an institution. And they don't want to be in an institution. And actually, the states and the federal government, it's more costly, so that it's not good for their budgets. And so this is a win-win. It's a wonderful opportunity. I think if we want to touch on any drawbacks here, health policy drawbacks, one of the criticisms is that there are some people maybe that would never elect to go to a facility that find a way to get eligible for home and community-based services because they are in need of help. And they call this sometimes is referred to as the quote unquote woodwork effect, that people will come out of the woodwork if you offer benefits because they're so popular and people need them. But again, the level of care assessments are comprehensive. People have to meet extensive criteria before being eligible. And this is largely substitutive care for facility-based services.
You beat me to the punch a little bit on the issue of cost because I was going to ask that next. We talked about how this helps people stay at home, and thematically through home-based care, we know if you're not in the institutional setting, you are saving the system money. in most cases. So let's talk about the current state of play that you alluded to at the beginning of our conversation. President Trump signed the One Big Beautiful Bill Act into law on July 4th. That doesn't have direct cuts for Medicaid HCBS, but we know these programs are likely still to be implicated. So what do we think this will look like when the bill does become implemented?
Right. So we have the One Big Beautiful Bill Act, or HR1, or the Reconciliation Bill. Truly was mostly tax policy. Okay, the vast majority of provisions within that law were intended to address tax issues, but there is a lot of changes in the Medicaid program. Okay, actually, Medicare was not really impacted in any real way within that law, but Medicaid policy was. And I think that your point's really important, and I want us to be thoughtful about how we talk about this. There are not cuts in any word or line in the One Big Beautiful Bill Act to home and community-based services. It's just not there. What is in there, and I think if you ask the people that advocated for it, they would say that it is largely cutting waste and abuse in Medicaid, okay? That they are trying to make sure that people are truly eligible, and they put in place, more checks and more process for determining eligibility. Also, for people that are able-bodied that are in Medicaid, they put in place work requirements that there's some either community engagement or work happening for these individuals.
So you've underscored that Medicaid HCBS aren't directly impacted, but let's go further into what could happen as a consequence of other cuts that are included in HR1.
Right. I think the worry is that with this amount of pressure on state budgets, look, we're talking about the Congressional Budget Office said that this law is going to take $1 trillion out of Medicaid over the next decade. Okay, $1 trillion is a lot of money, right? Let's be straight. Do you have $1 trillion? I'm looking.
No, I'm looking at you for $1 trillion.
All right, no, I don't have no trillion over here. All right, $1 trillion is a lot of money, and the states are going to have to address some funding gaps if they want to continue the services that they're currently offering, right? And so they are going to have to make some decisions in some instances, and I think that that's where the worry is. We don't know exactly how all the states will respond, and they're all in different circumstances, okay? Depending on if the states expanded Medicaid under the Affordable Care Act or Obamacare, they're in a different circumstance than others. Depending on which waivers they're using to implement different programs, they're in a different circumstance. So it's going to be different at a state-by-state level, but the concern is this amount of funding through something called provider taxes and the matching formulas being changed is a concern that states will feel the pressure and have to do something. And remember, home and community-based services are optional in state budgets, so they may be stuck with having to make some cuts and or cut back on availability, more wait lists. There are wait lists already. We have wait lists. I think there's several 100,000 people in the country. I don't remember the last number that are on wait lists for Medicaid home and community-based services. It's a big issue. And so we worry that the wait lists will expand. We know in the past that when there's been pressure on state budgets around the federal Medicaid funding, that they have cut back on services. And so that's the risk. There's another area that I don't want to overlook that's really important to mention is that when we talk about personal care workers, the personal care workforce, home health aides, attendants, many of them actually depend on Medicaid for their own insurance right now. It's a vulnerable group, the aides and direct care workers in many respects. And so another kind of concern here is what happens with all these hurdles and all these new requirements. Will any of them lose their insurance, and what will that mean for their stability and their ability to keep, providing caregiving and supporting their clients, their patients? It's that part shouldn't be overlooked.
Yeah, that's an essential lens to be talking about when we're talking about this. I mean, how many times are we going to talk about workforce on this podcast? But it's come up a lot for a reason. And what you said about the wait list is really interesting too, because a state might say, oh, we're not cutting this program, but instead they're just putting more people on the wait list. So in reality, those individuals are still not getting the support that they signed up for. They're waiting to receive it, but the program is still intact. So it's definitely something for us to keep our eyes on. When we're looking at the state level of advocacy and engagement, how do we make sure, what can we do to help make sure that HCBS are not impacted at the state level? Is it going to your state representatives and talking about the impacts of the program? What can we do to try to mitigate any potential harms?
Well, some of the provisions in this law don't go into effect for a year or more, and so actually there's even time, not just at the state level, but at the federal level, to revisit some of these provisions before they're implemented and the damage is done. And so there's some federal advocacy that we have to continue to work together on. Also, at the state level, I do want to highlight the incredible work done by state home care associations, state councils, their role in working with their state governments on Medicaid and Medicaid home and community-based service issues is critically important. They're usually small but really scrappy and influential and respected organizations in their states, and they are going to have to be vigilant about state budgets and what happens year to year in the budget cycle and how home and community-based services are impacted. I think, going back to one of the bigger overarching strategic topics that we talk about is that this is something that can save the state's budgets money, right? And so we're going to have to continue to remind state policymakers that actually, if you're feeling pressure in the budget, one of the strategic things that you can do is invest in more home and community-based services, expand eligibility, try to provide more opportunity for people for care at home rather than institutional care, which is often more costly. And so, not all policymaking is that strategic, and sometimes it's, we got an across-the-board cut from the federal government, so everybody's getting an across-the-board cut, or even worse, they target it at an optional program. But there might be some strategic ways that states can even invest more in HCBS.
Yeah, absolutely. And I think one of the things that we can encourage our members and other providers to do is share the stories of home and community-based service and supports. Because if we can share those stories with those policymakers at the state and national levels, then we can help them understand the support that they're providing to their constituents and why it's critical that they keep those programs in place and continue to fund them so they can operate effectively. It feels like we're back to the same refrain of please don't cut these programs. It's a short-sighted cut. It saves the system money in the long run. So once again, here we are with our same song and dance. Home-based care is preferred. It's a win-win. It saves the system money. Seems like a no-brainer.
We've got to continue to advocate and make sure that policymakers understand what it is they're working with here, because they're dealing with these massive budgetary issues. And there's no question that the math on federal and state budgetary issues is challenging, and we've got to make decisions. I think that it says something about us as a society, about how and where we make those decisions, about where our values are. And this is a program, Medicaid home and community-based services, that I think we should be as a wealthy nation, as a compassionate society. This is somewhere where we should be investing.
That's a perfect note to end on. It seems like we can't afford not to support these programs. And thank you for helping me learn just a little bit about Medicaid HCBS today. I know there's still a lot more that we haven't covered, but we've scratched the surface, and I think we did a good job there. I'm so excited to welcome the Alliance's very own Vice President of Medicaid Advocacy and Programs, Damon Terzaghi. Damon has spent his career working in programs that support older adults, people with disabilities, and low-income families. Currently, he heads up the Alliance's Medicaid-specific regulatory and legislative priorities, providing information and analysis to members regarding issues in Medicaid that impact home care, hospice, and home and community-based services. Prior to his role at the Alliance, Damon served as a senior director at Advancing States, the association representing state government aging, disability, and long-term services and supports agencies, and as vice president for the Marwood Group, where he led the group's Medicaid research practice. He's also served as a health insurance specialist for CMS and as a senior policy associate for the National Association of state Medicaid directors. That is certainly a mouthful. Damon, welcome to Who Cares? Being new to Medicaid policy myself, I'm really excited for this conversation because I know I have a lot to learn.
It's a really interesting space, and one of the great things about it is that I'm 20 years in and I still learn something new every day and never get bored.
That makes me feel a little bit better that you still have plenty to learn. Okay, so I know Dr. Landers earlier in this episode shared with us what Medicaid home and community-based services look like on the ground floor, but as, an expert yourself, I'd love to hear your perspective too. So how would you describe Medicaid home and community-based services, or HCBS as we're going to be calling them, to someone who is unfamiliar?
Think about just really meeting a person with some sort of disability or functional limitation where they're at in their homes. So the thing about Medicaid HCBS is that they're very, very flexible and they're very, very comprehensive. It starts with a personalized assessment of what the individual's needs are, what their preferences, what their goals for life are. And then it's creating an array of services that help them achieve whatever those goals are. And those goals, of course, are very, very different from person to person. Let's take a couple of examples. You may have a 25-year-old young adult with an intellectual or a developmental disability. For them, you start with that assessment of need, and they may have desires to enter the workforce. And there are home and community-based services that both provide what we call supported employment, where an individual has an aid that both helps them find a job, get the requisite skill development, and then provide hands-on support in the workplace to the individual. So it's a very employment, socially oriented support. In contrast, let's talk about an older adult, someone who maybe has worked their entire life, has aged into some sort of functional limitation. They're not really interested in going back to the workplace. Their assessment of need may be much more focused around in-home support getting out of bed if they have a mobility disability that prevents them from getting up in the morning. Support with medication or vital monitoring, more medical-like support in the home, as well as things like transportation to get out to community events. So there's really a wide array of things that fall under the rubric of home and community-based services. I would say the core one that most, if not all, individuals get is personal care services, really that attendant care, helping with activities of daily living, getting out of bed, those sorts of things, as I mentioned earlier. But even that doesn't apply to every single individual.
I really appreciate you painting the picture, using two specific examples. I think it helps people really put themselves in their shoes to understand. And I think what remains true across the home-based care communities that we serve as the Alliance is that person-centered approach, where it feels like these services really can be tailored, of course, depending on what's offered, but to the needs of the individual in order to help them, support their lives in their communities. I think the one thing that we can say is clear is that there's a lot of variance and a lot to understand. So let's, like you did with the example of the person who would receive support, let's dive deeper into a couple of state examples around what the program architecture looks like and how services may be delivered.
Absolutely. Let's start with a pretty straightforward one. Looking at the state of Montana, they're a state where they have several different home and community-based waivers, and the state operates all of this. So what happens is the state contracts directly with providers. Providers deliver the service. The state performs what's called case management. And case management is something in the Medicaid home and community-based services space that is crucial for establishing service plans. Case managers are responsible for doing that person-centered assessment that I talked about earlier, establishing eligibility for the individual for the waiver services, developing the plan of care and then authorizing the services and supports for the individual, and then ultimately making sure that they're delivered, that the person gets what they're supposed to be getting. So that happens based on entities that contract with the state to perform it. Then specific services, again, directly contracted with the state. The provider enrolls with the state. They perform the services for the individual, submit claims to the state, get paid that way. In contrast, let's talk about Tennessee. Tennessee has what we call a managed long-term services and supports environment. Pretty much all of their services are outsourced to third-party health plans. They have 3 managed care plans that serve statewide. And in that instance, the managed care plan becomes responsible for a lot of the different services and supports. They perform that case management function. They authorize the services. They ultimately adjudicate claims and pay the providers, do the provider enrollment, all those sorts of things. And it has many of the same dynamics that you see in the Medicare space with Medicare Advantage, where you have this third-party health plan. They have a financial risk associated with delivering the services. If they come in under their monthly allotment, they make a profit. If they go over their monthly allotment, they lose. So there's a lot of incentives associated with delivering effective care, delivering efficient care, and it creates some tension where some entities may argue that the plans are unnecessarily limiting care to make a profit, whereas others would say they're really right-sizing the services and making sure that the allocations are appropriate, that the services are delivered in effective, cost-efficient ways, and that the broader community of care is delivered kind of more effectively in global population health. And I think as with all things, the truth is somewhere in the middle, right? There's absolutely financial incentives and there needs to be protections in place for individuals. There's also some value of having those third-party plans to support and buttress what the state can provide.
Yeah. Okay. Wow. You were not lying when you said complex, but I have a couple of threads to pull on. I'm just thinking about all of the home care community providers that aren't already tapped into Medicaid HCBS. How would they work with an HCBS provider? Is that a normal relationship that we see? What advice would you even provide if someone wants to become more integrated with an HCBS provider in their community?
First of all, the advice I would provide is do it. It's a really important part of the care continuum. It's crucial for keeping individuals at home. Think about it from the perspective of if you're a home health and hospice provider but don't provide Medicaid home and community-based services, individuals in the home are the core of the business that you do. Without home and community-based services, the individuals are going to end up in a hospital or a nursing home or other long-term care facility. And that right there undercuts your entire business model. So having a viable provider community in your location is crucial, and having those relationships with providers in order to serve the individuals holistically and then also serve as a referral source is extremely important as well. So that would be the first advice, is make sure you're doing this if you aren't already, either through directly delivering Medicaid services or having a strong partnership with a home and community-based services provider organization or multiple ones in your community. Next, I would say start with what the Medicaid program looks like. I always say the best thing to do is kind of understand, at least at a high level, who's responsible? Who is providing that case management function I talked about? Are there managed care programs involved? Is it a county-based system? A lot of states actually run their Medicaid programs through their counties. So you're working with the county government, not the state government, at a local service delivery system. All of those things are very, very important in operating in this space. Next is determining who's delivering care in the region. Some states are very, very good and transparent at displaying the different provider organizations and having provider directories and those sorts of things available. Other states, it's a little bit more challenging to figure out exactly who's serving in that space and in which locations. But figure out where those entities are, who's out there already, and start to make inroads. The Medicaid home care system is overtaxed. There's a lot more demand than there is supply of care. And so entities and businesses and individuals in this space will always be looking for partnerships, will always be looking for ways to better serve their client base, better meet the needs of participants in the state.
I love where you started with my last question first. I think that really set the scene for everything that followed. And I think having worked in sales and marketing on the provider side as well, I mean, we're always working towards making sure that patient gets the right care at the right time in the hospice and home health world. Well, if we have an individual that we can start supporting prior to the time where they're becoming a patient of hospice or home health, then we can really walk them through that full continuum of care and provide that seamless, coordinated transition that we're all working towards always. And I think HCBS are not always part of the conversation when we're talking about that continuum of care. So it's really important that we started there. And I appreciate the call to action for everyone to really start thinking about this more than they already are. And of course, to your point about the limitations on services available, like be part of that solution. A lot of our provider network have the resources to at least get their foot in the door and see what they can do.
We've talked about this at various conference events and those sorts of things. A lot of people look at Medicaid as like a loss leader, like we're delivering services at a loss, but for the good of the community or for those referrals and those sorts of things. It doesn't have to be that way. And I would encourage people to go in with an open mind. Medicaid is a high volume, low margin business, but it doesn't have to be a loss when you're providing those services. So you can think about it not just as the on-ramp to your other services, but as a legitimate, sustainable line of business in its own right.
That makes a lot of sense. And of course, if you want to have access to an expert like Damon to learn more about Medicaid HCBS, the Alliance is a really great place to start asking questions. If you're not a member already, become one. But I want to bring us, I think we've done a really great job in a relatively short amount of time covering a lot of ground. It's been really informational for me personally. I want to bring it to the current day and think about some of the state of play that's happening. We touched earlier in the episode as well on the One Big Beautiful Bill Act, which has now, of course, been signed into law. So can you give us a download on any movement that we've seen since the legislation was signed into law? And what should providers be paying attention to now that things are starting to unfold or will soon be unfolding?
Well, as we're recording this, it's been about a month and a half since it was signed into law, and it's a very, very complex piece of legislation. So everyone's still, I think, parsing through and figuring out exactly what the nuanced impacts will be. What we're seeing right now is a couple of things happening. First of all, the states are starting to figure out exactly how this bill will impact their services, their programs, their finances directly. As we've talked about already, every single state program is very, very different from the others around the country. And so a bill like this that makes pretty significant changes to multiple parts of the Medicaid program is complex to understand. What we are seeing is states starting to project out high-level budgetary numbers. I've seen figures from Illinois, Pennsylvania, North Carolina, Colorado. A few other states are really starting to look at this. And the short answer is that they're projecting significant reductions in federal funding for their Medicaid programs as a part of this legislation. In some cases, it's multiple $billion a year. So what do we anticipate? We anticipate a pretty tough environment moving forward for the Medicaid program. States are going to have to figure out what to do about the loss of federal revenue. I foresee some backsliding, some loss of that progress as a result of this legislation as well. And the other thing I would say is that as much as we're concerned about the impact to home and community-based services and waivers in this space, the legislation actually tried to shield a lot of the impact from older adults, from people with disabilities. When you read the bill's language, they really, really try to target it to other parts of the program and maintain services and supports for older adults, people with disabilities. However, the reality is when you're pulling this much money out of the program, it's going to impact across the board. And we know that it will have negative impacts on those populations and the providers that serve them. But I bring that up because if we think about the negative impacts to us, there are other provider groups, other populations that are even more so impacted. Hospitals, for example, are really ground zero for a lot of the impact of this legislation, which means you're going to have allies, around the country in the effort to stave off these cuts, whether it be federal advocacy to reverse some of the most impactful changes, state advocacy to increase allocations to the Medicaid program. There are opportunities, I think, for partnerships to support Medicaid around the country with other groups that are similarly interested.
Yeah, I'm glad you framed it as allies. I think that's important, rather than an adversarial relationship where we're all vying for the same funds. Like, we are stronger with one voice. I mean, that's the whole shtick of the alliance. And we can have more of an impact if we all share, what the impact really is on the ground. Hopefully our legislators will listen, our states will listen, and we can start to move the needle. Obviously, I know there's a lot of work to do, and that's way easier said than done. But I think that's a positive spin that I really appreciate when I know a lot of this conversation really is difficult and scary. So one other piece of this that I just want to touch on before we conclude. So the Rural Health Transformation Fund, I know there's been some conversation. What should I know if I'm a provider? What are you seeing providers trying to do to potentially lobby for some of those funds? And is there viability there? Or is this another one of those, we'll try to put a positive spin on it, but we don't know situations?
The legislation did have pretty significant cuts to Medicaid. And so as a way to try and alleviate some of the greatest impact in rural areas, Congress included this Rural Health Transformation Fund, which is about $10 billion a year for 5 years. So $50 billion in total. The legislation's a little bit challenging insofar as the greatest impact from the cuts occurs after that 5-year period. So this money comes first and then dries up before the biggest cuts go into effect. But it does give an opportunity for rural areas, for rural providers to gain some extra support and hopefully build up a little bit of a buffer and buttress themselves from negative impacts of the healthcare cuts in this One Big Beautiful Bill Act. So the legislation has been talked about nationally about a rural hospital fund. But when you read the bill, it's not just for hospitals. It actually defines healthcare provider as any entity that is enrolled in Medicare, Medicaid, the Children's Health Insurance Program as a provider or supplier. So pretty much everyone listening to this podcast would qualify, if they are delivering home health, hospice, Medicaid, home and community-based services, or other supports. as with everything we've talked about so far today, it hinges on state decisions, exactly how it will be used. We are starting to see some movement on this front. Several states have put out requests for information and have solicited feedback on how to prioritize the funding, how to use the resources once they're received. The state of Alaska, in their request, actually specifically called out home and community-based services as a priority area for utilizing this rural health fund. And what state has more remote areas than Alaska? They're obviously very ingrained in rural health and thinking about this holistically. In contrast, what we saw from Texas in their information that they put out publicly was very, very much focused on that rural hospital angle. So kind of very, very core, not very flexible. We, of course, are advocating for them to take a more holistic view and include home-based care, but their initial thinking does appear to be a little bit more hospital-oriented. And then other states haven't maybe put out formal information, but have begun conversations either through advisory boards or discussions with their advocacy and provider communities. I know several of our members, some of our state-based affiliates, partners at the state level, have begun those conversations with their state agencies and are actively encouraging inclusion of home and community-based services and home-based care. So I would really encourage everyone listening, get on this now. This is moving quickly. The federal government has until December 31st of this year to issue awards, which means that states are going to have to put together their plans for how to spend it well before that December 31st deadline. They're making these decisions now, so we really do need to be proactively making the case for why home-based care, for why home and community-based services are crucial components of the delivery system that absolutely need to be included in rural health delivery plans.
Yeah, that's an incredibly consolidated timeline. So there really is a strong urge to act now because it's now or never. But we'll definitely have to have you come back on and talk more about what we're seeing once this actually does unfold. And some of the funding has been awarded. I know we're coming close to the end of time, but I do just want to ask one final question, because I think what has been made abundantly clear to me throughout this conversation is that I don't even know what I don't know. And so I want to make sure that I'm asking the right questions and giving you the chance to kind of share what you think will be most valuable and beneficial to those listening. So final thought, and I'm kind of going to paraphrase how I was originally thinking about this, but I feel like I've learned so much. What do you wish more people knew about Medicaid HCBS? As a final closing note, I feel like there's a lot that you could say based on the conversation, but I'm sure you've thought about that quite a few times over the course of your conversations the last 20 years.
I wish people knew how truly and important and valuable and transformative it is in the lives of individuals. When I started out my career, I worked for the state government, the state Medicaid agency in Oregon. And one of the things Oregon did really, really well was they forced us to get out of the cubicle world, out of the big walled state buildings and out into the community. And I had opportunities to travel around the state and engage with people who received services. And I'll really never forget a lot of those instances, whether it was a guy who was so excited to show me the van modifications that he had that allowed him to drive, an individual who had quadriplegia, had never been able to drive before. And he was so excited to show me his tricked out van. I got to go on a job shadowing with some of that supported employment stuff I talked about earlier, community centers around the state. And it was just so enlightening to see really the important role that Medicaid plays, Not in the medical health insurance side of things, which is also crucial, but really in that just enabling individuals to live a life, to be, a normal person in the community, which is kind of what we all want for ourselves and for our families. And I think that kind of knowing that and understanding that this is the perspective we're coming from as those who care about the program is something that sometimes gets a little bit lost when you talk through the complexities of, case management and service delivery and assessments, or the budgetary numbers of, this Medicaid waiver in and of itself is a $6 billion a year program. People lose that ground level perspective. And that's really where I would always start. I'm a nerd on policy. I love getting into the nuances of legislation and regulation and the math behind it all. But at the end of the day, it all comes back to that individual who's sitting at their family table having a meal with their loved ones because they can. And without these services, they would be alone in a nursing home.
Thank you for sharing that. I couldn't think of a better note to end on. I actually have chills from that last picture you painted, but I think, I can't say it any better. It's all about helping more people, and what we can do to humanize the conversations that we're having will have a role in making that possible. So thank you for this conversation. It's been amazing. I've learned a lot. I feel like we've covered a ton of ground. I know we're going to need a part 2 for all the ground that we didn't even scratch the surface of. But yeah, thank you again. It's been a pleasure. If HCBS are new to you, or you are hoping to learn a little bit about how this new legislation could be impacting these services, I hope you learned a little bit throughout the course of this episode. We'll see you in the next one.